Hello, and welcome to this updated presentation on point-of-care ultrasound and cardiac arrest. I'm Michael Trower, an emergency medicine consultant from London with a postgrad diploma in medical ultrasound, and over the next half hour we'll cover the potential roles of ultrasound in arrest, the evidence for its use, as well as some formal protocols and practical tips for how it should be used. Let's start with a case. A 73-year-old female has an out-of-hospital cardiac arrest. She was found unresponsive, so there's an unknown downtime. She receives bystander CPR for 5 minutes. The paramedics arrive and continue with advanced life support for a further 15 minutes. The initial rhythm is PEA, but when she arrives with you in the emergency department, she's in asystole, and her end tidal CO2 is 0.7 kilopascals. A subcostal echo is performed, and this is what you see. So in the near field, this is the right ventricle. In the far field, this is the left ventricle. I'll just give you a few seconds to look at the clip, put that together with the case, and think about, if you were the team leader, what would you do at this point? Would you continue the resuscitation, or would you stop? So there's no right or wrong answer here, but I think the prognosis for this lady is unfortunately very poor. She's had 20 minutes now of chest compressions with no ROSC. She's in asystole, which is the rhythm with the poorest prognosis, and her end tidal is less than 2 kilopascals, which again is a poor prognostic sign. When we look at the echo clip, if you look closely in the near field, there is some movement of that right ventricle, which is a good prognostic sign. However, when you factor it in with everything else, the overall prognosis is still very bleak. So I think it would be reasonable to stop here, but on the other hand, it would also be reasonable to continue for perhaps 2 or 3 more cycles to see if there is any possible positive outcome. Case 2. This time a 39-year-old female has an out-of-hospital cardiac arrest. She was witness to collapse, so has immediate CPR, which lasts for 5 minutes. Then the paramedics arrive and deliver ALS for a further 10 minutes. Her rhythm, both initially and on presentation to ED, is PEA, and her end tidal is 2.5. This is a parasternal long axis view of the heart. So in the near field, this is the right ventricle. Blood then goes to the lungs, comes back to the left atrium here, out through the mitral valve, which we can just see here, into the left ventricle, and then out the aortic valve into the ascending aorta here. So again, take a few seconds to look at the clip, put it together with the clinical information, and think about what you would do if you were the team leader. Would you continue or would you stop? So in this example, there's no cardiac activity on ultrasound, which, as we'll see, is a poor prognostic sign. However, all the other factors are pointing towards a favorable outcome. This is a young patient who had immediate CPR with no downtime. They've only been in arrest for 15 minutes. Their rhythm is PEA, which is a better prognosis than asystole, and their end tidal is above 2. So even though there's no cardiac activity on ultrasound, I would definitely continue with resuscitation for this patient. Case 3. A 65-year-old man has an out-of-hospital cardiac arrest. He's found unresponsive, so unknown downtime. He has bystander CPR for 5 minutes. Paramedic delivered ALS for a further 10 minutes. His rhythm degenerates into asystole on arrival to ED, and his end tidal is just below 2. This is the subcostal echo view that you see. So we have the right ventricle here in the near field, and the left ventricle here in the far field. So think a bit again about what you would do if you were the team leader for this patient. And I should point out that what you can see in the echo clip is not actually cardiac activity. This is actually the patient being ventilated. If you scan the heart while the patient is receiving ventilations, you often see this movement because the heart is being pushed side to side by the inflating and deflating lung. If you actually look in the far field at the left ventricle, there's actually no cardiac activity. This is all just movement from ventilation. So overall, this patient has a pretty poor prognosis. There was an unknown downtime. There's been no ROSC for 15 minutes. He's now in asystole with an end tidal less than 2, and there's no cardiac activity on ultrasound. So there's no right or wrong answer. I think it would be reasonable to stop here, but also it would be reasonable to continue for 2 or 3 more cycles to see if there's any chance of a positive outcome. Traumatic cardiac arrest is really a different kettle of fish, so we're not going to be talking about that today. There's an established protocol for this situation involving finger thoracostomies, blood products, thoracotomy if necessary, and I think ultrasound should not delay these important life-saving procedures. Similarly, we won't focus on shockable rhythms today, because obviously here the priority is early defibrillation. The only real potential role of ultrasound here is differentiating fine ventricular fibrillation from asystole. If you look very closely at this clip, it's most easily seen here in the interventricular septum. There's a quivering movement of the muscle fibers. If you see this, you know the patient is actually in VF, even though it may not be apparent on their ECG or on the defib monitor. Before we talk about the potential benefit of ultrasound in cardiac arrest, I think it's important to first note the potential harms. And the main one here is delaying chest compressions. We know that if chest compressions are delayed for more than 10 seconds, this relates to a poor outcome for your patient. So we really must not let this happen. And the responsibility for this is both with the provider performing the ultrasound, but also the team leader. Having said that, there are actually several potential benefits of using ultrasound in cardiac arrest, which I'll outline here. First, predicting outcome, as we have alluded to with those initial 3 cases. 2, identifying reversible causes. 3, identifying pseudo-PEA. 4, ensuring effective chest compressions. 5, identifying ROSC. And 6, vascular access. The most important study that's been published on ultrasound in cardiac arrest was by Gaspari in 2016 from North America. This was a prospective multi-center study of nearly 800 patients. They just looked at PEA or asystole, so they excluded shockable rhythms and also traumatic arrests. And the main outcome was survival to admission. And they found that if there was cardiac activity on ultrasound, the odds ratio for survival was 3.6, so it was a good predictor of survival. Digging down into this a little deeper, if we look at patients where there was no cardiac activity or cardiac standstill, only 14% achieved ROSC, compared to 51% who did have cardiac activity. Still fewer, only 7% survived to ICU admission, compared to 29%, and only 0.6% of patients who had no cardiac activity on ultrasound survived to hospital discharge. This only represents 3 patients. However, I think it's important to point out that while the absence of cardiac activity is clearly a poor prognostic sign, it is not absolute. There were still some patients who made it home despite having no activity on their initial ultrasound. The second role of ultrasound in arrest is identifying reversible causes, and in my opinion, this is the most important role. I'm sure you're all familiar with the 4 H's and the 4 T's. I'll list them here for you. Now, which of these can be identified with ultrasound? Tamponade, absolutely. Thrombus, yes, a PE can be identified. Tension pneumothorax, certainly. And also hypovolemia. So actually half of these, 4 out of 8 of these reversible causes can be identified with ultrasound, and we'll now go through each of them one by one. Tamponade. In the Gaspari paper, 34 patients had pericardial effusions identified. 13 of these underwent pericardiocentesis, and 2 of these survived a hospital discharge. So quite small numbers, but still, if you do see pericardial fluid, you should be prepared to drain it, because if you do, this group will have a better outcome. In terms of performing pericardiocentesis, there are a few different approaches, but I think the key thing is to have mentally rehearsed how you're going to do this before you actually need to do it. There are dedicated pericardiocentesis kits, but I think it's also reasonable to use equipment that you're more familiar with. For example, the procedures I've performed, I've used a central line kit. Ideally, it should be done with ultrasound guidance, and ideally in-plane needle guidance. And in terms of the approach, you can go for the standard traditional subcostal approach, pointing to the patient's left shoulder, going through the liver. However, if you can get a view of the pericardial fluid intercostally, then I think it's also reasonable to go where the fluid is at its most deep. And if you can see the heart, then you know there's no lung in between and you shouldn't be causing a pneumothorax. The second reversible cause that we can identify with ultrasound is PE. However, right ventricular dilation is actually not specific for PE. Aagaard, a Danish researcher, took 30 pigs and put them all into cardiac arrest through different mechanisms, and found that actually in all of the pigs, the right ventricle dilates. So this is just something that happens when the heart stops. Because the RV is a thin-walled chamber, it just tends to blow out. And so this finding is not specific for a PE. However, Nazarian found that DVT is extremely specific for a PE. In this clip, we can see the popliteal vein in the near field and the popliteal artery behind it in the far field. And as the operator is compressing with the probe, that popliteal vein is not coming together. The walls do not meet. And you can also see echogenic thrombus within the vein. If you see this in the context of a cardiac arrest, this is highly specific for a PE, and you could thrombolyze just based on this finding. In the Gaspari study, 15 patients received thrombolytics, and 1 of these survived a hospital discharge. So if you see a DVT and you think PE is the cause of the arrest, then you should be prepared to treat it. The third reversible cause that can be identified with ultrasound is tension pneumothorax. Here's a clip of normal lung. In the near field we have muscle, on the sides we have ribs with shadows, and then just deep to the rib we have the pleural line, this bright white shimmering line. Because the visceral and parietal pleura are together, as the patient breathes in and out or is ventilated, we see a shimmering movement along that line, which is normal and rules out a pneumothorax. In this second clip, we have lost that lung sliding. Here is the pleural line, but it is static. There's none of that shimmering back and forth movement. This is not 100% specific for pneumothorax. However, this is what you will see if there is a pneumothorax. This third clip shows what's called the lung point. So on the left of the image, there's no sliding, and to the right of the image, there is sliding. This represents the junction between pneumothorax and normal lung that is coming up to the chest wall. However, in a cardiac arrest, it's likely a tension pneumothorax, so the whole lung will be collapsed, so you will not see this lung point. So in an arrest, we're just looking for absence of lung sliding across that whole side of the chest, and we're obviously correlating that with our clinical findings, percussion, auscultation, tracheal deviation, and deciding if we think a tension pneumothorax is a likely cause for the arrest, then we should be prepared to perform an immediate finger thoracostomy. And the final reversible cause that can be identified with ultrasound is hypovolemia. we may see signs of hypovolemia, so a narrow collapsing IVC or kissing LV walls, but we may also see causes of hypovolemia, for example, a AAA or free intraperitoneal fluid. So if we see any of these things, we're obviously going to be thinking about aggressive volume replacement. The third role of ultrasound in arrest is identifying pseudo-PEA. This is a somewhat controversial term. PEA, as you know, is pulseless electrical activity, and pseudo-PEA is when you can see organized cardiac activity on the ultrasound, such that you would expect some kind of cardiac output. However, there's no pulse and there's no blood pressure. Gaspari looked at this specific subgroup, over 200 patients, and found that if the patients were given a continuous adrenergic infusion, for example, a noradrenaline infusion, then their survival to admission improved. And this makes sense. Rather than just giving the unphysiological ALS protocol of adrenaline boluses every 4 minutes, if the heart is already trying to beat, surely it makes sense to support this intrinsic heart activity. Now, this doesn't mean we should be stopping chest compressions. We should be continuing chest compressions until we can confirm there is adequate cardiac output to perfuse vital organs. However, we should be simultaneously starting a continuous infusion as soon as possible in this group. This smaller study also showed benefit from additional vasopressin in patients with pseudo-PEA. And so in my practice, if I can see there is organized activity on echo, I will always try and get this group onto an infusion as soon as possible. The 4-minutely adrenaline boluses in the ALS protocol is really based out of practicality rather than physiology, and now we also have evidence to support getting this group onto infusions as soon as possible. The fourth role of ultrasound in cardiac arrest is ensuring efficacy of chest compressions. These MRI and CT slices show that if we just compress in the standard position, the lower half of the sternum, we're actually often over the LVOT or the aortic root rather than over the left ventricle where we should be. And there is also now evidence that this is the case. This small study using transesophageal echo showed that if we just use the standard approach of the lower half of the sternum, the area of maximal compression is usually over the aorta or the LVOT. This clip is a transesophageal echo. I'll give you a few seconds to watch it. It does slow down, and hopefully you can appreciate that the LVOT just here is being completely squished by chest compressions. And so, as you can imagine, there cannot be any meaningful output through the aorta if the outflow tract is being completely compressed during compressions. By contrast, this clip shows what we should be aiming for. The left ventricle is being compressed and the LVOT remains open. And unsurprisingly, if you compress over the correct part of the heart, you get better outcomes. This animal study showed that if you compress over the LV, you get a 70% rate of ROSC versus 0% over the aortic root. And this human study showed that there was a good chance of ROSC with an open LVOT, but a very poor chance with a closed LVOT. The fifth role of ultrasound in arrest is identifying return of spontaneous circulation. There are various ways that we can identify ROSC. We could feel for a pulse. We could look for a rise in end-tidal CO2. We could look at the heart and see if it's beating. Or we could use Doppler. If you have an arterial line in, that is obviously the gold standard, but in many cases you won't have this available. So we're going to focus now on using Doppler to identify ROSC. We know that manual palpation of the pulse is unreliable. In some studies, its accuracy is only about 50%, even less when it has to be done quickly. And I'm sure you've all been in situations where you have 2, 3, even 4 people feeling a pulse. Some of them think they can feel a pulse. They're not sure if it's their own pulse. the team leader might be getting different interpretations, and it can be really difficult to know, does this patient have a ROSC or not? If you cycle a blood pressure, this could take another minute, and if there's no pulse, you may have lost the patient in that time. So it's really crucial that we can accurately identify ROSC as soon as it occurs. So how can we use Doppler to assess pulse and identify ROSC? Well, there was a study published on this topic by Haddad et al. From North America, 2023, and they found that it's actually relatively simple and appears to be more reliable than either manual palpation of the pulse or end-tidal CO2. First, a quick recap on Doppler physics. So Christian Doppler was a 19th century Austrian mathematician and physicist, and the Doppler effect is most easily described by the sound of an ambulance coming towards you and going away from you. So as the ambulance goes away from you, the sound frequency reduces, ni-no, 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 ni-no. And as it comes towards you, the frequency increases, ni-no, 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 ni-no. And this can be measured using the Doppler function on your ultrasound machine. When using color Doppler, the mnemonic to remember is BART, blue away, red towards. Here we can see that the renal veins are flowing away from the probe, but the renal arteries are flowing towards the probe. As well as color Doppler, there's also spectral Doppler, and there's two types of spectral Doppler, continuous wave and pulse wave. Today we'll just focus on pulse wave, which is where you have the gate and you're just measuring Doppler signal within that gate. Traditionally, to measure velocities in a blood vessel, we should align our Doppler signal as closely as possible with the vessel. So in this image, you can see that the color Doppler box has been angled so it's more parallel to the artery. And when you press pulse wave again, that activates the graph at the bottom of the screen, and you can see the typical triphasic arterial signal. However, if you put the pulse wave gate on the artery in transverse, you will actually still see a signal, even though we're now measuring Doppler signal perpendicular to the flow of blood. Actually, you will still see a signal, and this is what they did in the Haddad study. So in Haddad et al., they looked at 35 patients, and they found that a peak velocity of more than 20 centimeters a second related to a ROSC with a systolic blood pressure of more than 60 millimeters of mercury. And they found this was pretty accurate, around 90%. If you are going to use this, make sure you've thought about it before your patient arrives in cardiac arrest. Use the linear high-frequency probe and know the presets and Doppler scales of your machine. In general, you'll want to be using an arterial preset. If you use a venous preset, the Doppler scale may not be suitable to be able to measure whether there's more than 20 centimeters a second of velocity. You can slightly tilt the probe towards the patient's head just to bring out a more clear arterial waveform, and put the pulse wave gate in the middle of the femoral artery. Okay, the final role of ultrasound in arrest is vascular access. ALS teaches that if we can't get IV access quickly, we should go straight for intraosseous access, which I totally agree with. However, with ultrasound, we can often get IV access very quickly. Often I'll put a long peripheral cannula into a central vein. Where I work, we have deep access 64 millimeter cannulas, and these can easily reach, for example, the femoral vein. Also, arterial lines can be inserted during arrests or even during a brief ROSC, and again, this should be done with ultrasound guidance. As we said at the beginning, ultrasound in arrest can cause harm if it delays chest compressions, and so it's crucial that we've prepared and know exactly how we're going to use it before the patient arrives. Ideally, we would have also gone through this in some kind of a simulation as well. So who's going to be performing the ultrasound? Ideally, not the team leader. When are they going to perform the ultrasound, and how are they going to perform the ultrasound? Several protocols have been described. Feel just looks at the heart. Cause also looks at the lungs. Shock, SHOC, also looks at DVT and AAA free fluid. And Sesame looks at these same items but in a different order. Shock, SHOC, has protocols both for hypotension and for cardiac arrest. And the principle here is flexibility. You start with the core scan, so you look at the heart, then you look on supplementary views, so the lung and the IVC, and then only if necessary you move on to the additional views, for example, confirming ET tube placement, DVT, and AAA and free fluid. This is the shock protocol for cardiac arrest. So we start with the heart and we look for pericardial fluid, RV, LV, size and function. And if we have enough information already, we can stop there. If we need more information, we can move on to the supplementary views of the lung and the IVC. And again, if that gives us the information we need, we can stop. But if we want more information, we can then move on to the additional views, looking for free fluid, AAA, DVT, and confirming ET tube placement. So the principle here is that we shouldn't just blindly go through the whole protocol. If we've identified at the beginning that the patient has a large pericardial effusion, we shouldn't be wasting time checking their AAA and DVT. We should just be moving straight ahead and treating what we find. And this is the Sesame protocol, designed by Daniel Lichtenstein, a professor from Paris who's responsible for a lot of the evidence on lung ultrasound. And I love how he calls this a really fast protocol. In terms of the timing, these are actually seconds, so you can see how quickly you're expected to perform this scan. You should be aiming to perform the lung scan in 10 seconds, DVT in another 10 seconds. It's all very, very quick, and I think this is actually key. The person who's performing the ultrasound should be an expert. They shouldn't be spending minutes finding each view. They should be able to run through the whole protocol as quickly and swiftly as possible to minimize any delays to chest compressions and get all that information to your team leader as soon as possible. I think it's important to keep things flexible and not be slaves to protocols. Obviously, if you have a tall, thin male who had sudden pleuritic chest pain and then collapsed, then we want to start with lung sliding. Similarly, if you have a patient with a swollen right leg who's had a PEA collapse, we might want to start with DVT. So keep things flexible based on the patient in front of you, but it's also good to have those protocols in mind to fall back on. In my practice, I'll usually start with the echo, and I'll mainly be looking for tamponade, RV dilation, and whether there's any cardiac activity or indeed pseudo-PEA. Then during chest compressions, I'll look for the other reversible causes: lung sliding, hypovolemia, and DVT. But I'll be flexible about this order. For example, if there's a delay moving the defib pads across, there may be a moment before the initial rhythm pulse check, and I'll jump in and have a look at lung sliding first. Then, once we're ready for the rhythm pulse check, I'll look at the heart, usually a subcostal view, looking for those three things. And then during chest compressions, we can look for the other reversible causes, hypovolemia and DVT. As well as those reversible causes, we can also use ultrasound, as we've said, to obtain IV and arterial access. We can also have some idea whether our chest compressions are being effective. Transesophageal echo would be the gold standard for this, but even with transthoracic echo, we'll have an idea whether the chest compressions are over the LV or over the LVOT or aorta. And we'll also be able to see whether there's flow coming into the femoral artery. And if we're concerned there's not effective chest compressions, we can always move either the manual or the Lucas lower down towards the xiphisternum. We can also identify ROSC by looking at that peak velocity on pulse wave Doppler over the femoral artery. And finally, we can confirm endotracheal tube placement. Of course, we're going to be relying heavily on end-tidal CO2 waveform. However, ultrasound can have a useful additional adjunctive role to confirming ET tube placement. In this image, you can see the trachea, which has a bright anterior convexity and then a shadow behind it. And the esophagus sits either to the right or to the left of the trachea, and it's a grey or isoechoic structure, oval-shaped and without shadowing. However, in this second image, we can see there's an endotracheal tube within the esophagus. So here's the main trachea, and it's like there's a little baby trachea next to it. So here we have a bright convexity at the anterior aspect of the esophagus and a shadow behind. So it's like you have the mummy trachea and a little baby trachea next to it. Here is a clip of tracheal intubation. The trachea will look similar whether there is an endotracheal tube within it or not, because either way it's still just an air-filled structure. However, you will see some movement within the trachea as the tube passes through. And here's a clip of esophageal intubation. This is what we do not want to see. So here is the trachea, and the esophagus, which sits to the right of screen of the trachea, suddenly becomes like a little baby trachea as the endotracheal tube passes into it. So if we see this, we should be immediately telling the intubator, I'm afraid it looks like you've gone into the esophagus and you need to pull back. Some take-home points from the talk today. Point-of-care ultrasound can identify several of the 4 H's and 4 T's. In fact, 4 out of the 8 can be readily identified, and I think this is the most important role of ultrasound in arrest. DVT is highly specific for PE. Right ventricular dilation is not, but if you can see a DVT, this can rule in a PE and could be the basis for thrombolysis. And actually, a quick 2-point compression DVT scan can, with experience, be performed quite quickly during chest compressions. If you can see on echo that the heart is trying to beat, there's organized activity, I would recommend trying to get these patients onto continuous inotrope infusions as soon as possible. Ensure that your chest compressions are actually over the left ventricle and not over the LVOT or the aorta. It turns out if you just use the standard lower half of the sternum approach, you'll often be too high up towards the base of the heart. So if there's signs of poor perfusion, low end tidal, a lack of flow into the femoral artery, consider moving your chest compression position down towards the xiphisternum. And finally, consider using pulse wave Doppler over the femoral artery, looking for that peak velocity of more than 20 centimeters per second, because we know this correlates with a systolic blood pressure of more than 60. If you have any questions or comments, I would love to hear from you at my email address, michael.trower@nhs.net. And I would love to hear from you in the comments below the video. If anyone has experience using pericardiocentesis in arrest, I'd love to hear your thoughts and experience. Similarly, using inotropic infusions in that pseudo-PEA group, transesophageal echo in arrest, or ECMO CPR or eCPR. Please, let's have a chat in the discussion in the comments below. Here are my references and resources. Thanks so much for your attention, and I'll see you soon at another video on point-of-care ultrasound.